Hi, today we should discuss CPD and mental health. And this is a case study about CPD and anxiety. My name is Bjorn Stallberg. I work as a GP in mid-Sweden and doing research at University of Uppsala. And then, Liz, who are you?
Hi, I'm Liz Steed, and I'm a senior lecturer in health psychology. I work at Barts and the London Medical School, part of Queen Mary University of London in the UK.
And the aim of our presentation is that highlight the importance of assessing for and treatment for anxiety in our patient with CPD. And we will also provide a case study where we will discuss evidence-based intervention. And in this presentation, we are very focused on anxiety and what it means in people with CPD and how we can improve the management of patients with CPD and those who have also problems with the anxiety. And we will also discuss how we all can be a part of that change. First, something about the prevalence and impact of anxiety in CPD. We know that anxiety is a significant problem in CPD, perhaps an estimated prevalence up to 40%, 4 of 10. And we know that people with CPD are more likely to experience panic disorder or panic attacks compared with the general population. And we also know from other studies that anxiety is associated with impaired health, related quality of life, and also, which is important, increased mortality risk. Now, to our case from our practice. First, a bit background. This is Johan. He's 68 years old. He retired 4 years ago, and before that he had worked as a bookkeeper in a small office for his nearly whole life. He lives alone in a small town, 2 children and 5 grandchildren. He really enjoys reading, and earlier he used to walk a lot, but due to his breathlessness, now he prefers to stay at home. And some medical history of our patient. He has hypertension, type 2 diabetes, and of course those CPD, and some medications, amlodipine, enalapril, atorvastatin, metformin due to hypertension and diabetes, and also a fixed combination of LAMA-LABA and also short-acting beta-2 agonists as needed for the CPD. He's a bit obese, BMI 33. Now he has a routine checkup with his GP. He usually goes to his GP twice a year and usually renews all prescriptions when visiting his GP. I think you all can recognize this patient from your own practice. I hope so. And something about the respiratory history. He has been a smoker since age 14, still a daily smoker. 10 years ago, he was diagnosed with CPD, and the last spirometry performed a year ago showed that FEV1 55% predicted. It's gold stage 2, and then a ratio 0.55. He has had fixed combination LAMA-LABA for the last 5 years and also short-acting beta-2. Typical CPD respiratory history. When we read the note from a previous visit, we can see that the patient experienced breathlessness when walking with people of the same age. He has just had one severe exacerbation, and that was 2 years ago. He has often night symptoms with cough and sometimes breathlessness. And as many COPD patients, he uses his extra SABA, short-acting beta-2, daily, but with limited effect on the breathlessness. So this time, Johan had scheduled a routine checkup, and at the same time we took some blood tests, and it was good diabetes control and blood pressure acceptable, not perfect. And his GP, as usual, and as we often are, he was a bit rushed. So on the question, how are you? The patient answers that his COPD is a bit worse, more breathlessness. Everything seems to be harder. He thinks it's difficult coping that. But he also needs a new prescription of short-acting beta-2. So what did the GP? They acknowledged COPD is a hard condition to live with and prescribed more short-acting beta-2 canisters, this time 3, and also prescribed and renewed all other medication for Johan. And together they agreed with a new appointment in 6 months. And as we always are, we are late, so the GP rushed to see the next patient. Liz, what do you think?
Thank you. Next slide, please. So at this point, we'd like you to pause and just reflect for a moment. Next slide, please. Is this a typical case you might see in your care? Would you do anything differently? Do you think anything is lacking or could be done to improve the consultation? Are there clues something else is going on? Next slide, please. So the consultation appeared friendly and was aiming to take a patient-centred approach, particularly by acknowledging how hard it can be to manage COPD. But did they really deal with the comment about not coping and increasingly staying at home? Just asking people to expand a little on these things can be important. We know from previous studies that often GPs not only don't explore, but can actively close down clues to mental health concerns. Slide 19, please. Our desktop helper goes through some simple ways to ask questions to get people to open up. This includes using open questions such as, tell me about what's going on when you feel breathless. Making affirmations such as, it's great that you're happy to talk about how you feel. Reflections, which can show empathy. For example, it sounds like this is a really tough time. And summarising what the person has said, both to check and show you understand. The desktop helper also explains a model of how an individual's breathing is related to not only their functioning, but also their thinking. For example, if someone, when they become breathless, has the thought, this is a sign my illness is getting worse, I can't control it, they may avoid activities that make them breathless. This is then likely to lead to deconditioning and poorer functioning, so breathlessness occurs at a lower rate of assertion, feeding that thought that the illness is getting worse. Next slide, please. The idea that anxiety is related to thoughts, feeling, behaviour and symptoms is shown on this slide here. By listening out for clues in any of these areas, it will help you suspect that anxiety is a possible problem. Next slide, please. In your practice, if you want to quickly screen for anxiety and or depression, you can use the PHQ-4, which can be very helpful. If anxiety is indicated in the top 2 items, then you may want to go on to use the more comprehensive GAD-7. Next slide, please. This has a number of items, And if there is a score of 8 or more, it indicates that anxiety may need to be managed. Next slide, please. The GAD-7 is also freely available internationally in your own language and has been validated in different languages and can be downloaded from the internet. And we would encourage you to access this. So, having diagnosed anxiety, the next thing to consider is how to manage it. Whether you make referrals or what you advise patients will depend on what is available within your country. Here in the UK, we have a primary care service called IAPT, Integrated Access to Psychological Therapy. This offers patients a form of psychological treatment called cognitive behaviour therapy, which works with the ideas presented before, that how someone thinks about their symptoms and condition is likely to influence what they do, how they feel, and how they experience symptoms. Next slide, please. Systematic reviews have suggested this treatment can be beneficial in reducing anxiety and depression symptoms in people with COPD, as well as improving their quality of life and decreasing breathlessness. It is important to know, though, that the length of treatment and how successful it will be may vary depending on when it's offered and how complex a patient's problems are. Next slide, please. Now, we know sometimes it can be difficult to raise psychological issues with patients, and GPs can have low confidence in this. This slide shows some tips on how to go about raising the idea of psychological treatment. For example, start by saying that, as with any chronic illness, in COPD, our psychological or emotional health can be affected just as much as our physical, and it's just as important to manage that too. You can highlight that many people with COPD suffer from anxiety, but we suggest you try and avoid saying it's normal, as this can make people think it doesn't need to be managed. You may then suggest a referral and say you'd like to see them in 6 to 8 weeks to see how they are getting on. Next slide, please. This slide shows the words we use when referring people for CBT. A tip I have as a psychologist is then to ask how likely or confident they are that they'll follow the advice you have given on a 1 to 10 scale, where 1 is very unlikely and 10 is definitely. If people come back and say they're lower than about a 7 or 8, they may not be likely to follow your advice. So it can be helpful to go back and explore what the barriers are and make a plan that the person is more likely to be able to follow. Next slide, please. So in this case study, we have focused on cognitive behaviour therapy, but there are other ways people can manage their anxiety. These include things like mindfulness or relaxation, for which there are many freely available apps. Also, some people find acupuncture helpful, whilst others find singing groups help both breathless and their quality of life. You can find these other ideas on our IPCRG desktop helper. Back to you, Bjorn.
Thank you, Liz. We have a focus on anxiety in this presentation, but of course our patient was smoking, and we know that smoking cessation in people with COPD is so important. And we also know that mental health problems are associated negatively with smoking, successful smoking cessation. And there is another case study discussing more around smoking cessation, and this is a slide with some good advice how we could support smoking cessation with ask about smoking, advise the patient, and also how to act according to the patient's response. You can read this. And if we go back to our patient, Johan's consultation, now it was revised. You acknowledge CPD is a hard condition to live with, and we use the questionnaire PHQ-4 and note that further assessment for anxiety was needed, and he then scores 10. And you note that at this time he's not presenting symptoms of depression, but make a note to follow up this at the next visit. And if it's possible, you arrange for CBT referral, or you do it and schedule a new consultation at a later date. It can be different in different countries. And you also agree with the new telephone review to see how the CPD is progressing. And then, of course, ask, advise, act on smoking cessation. So, in summary, it's important when reviewing a person with CPD to evaluate all comorbid conditions, not only heart disease, but also depression and anxiety, and diagnosis and intervention to treat comorbid anxiety and depression in people with CPD. It will improve the quality of life and also, that's important, their CPD outcome. Thank you. Thank you, Liz.
Thank you, Bjorn. I hope you've enjoyed our case study and it has been of some help.